At the outset, then, I would like to invite Professor Ruchi Goel. Well, Professor Ruchi Goel needs no introduction. She is one of the pioneers in small incision cataract surgery. Can you see ma'am's profile?
We can see. We can
Yeah.
see.
And she, Professor KPS Malik, has been the author of one of the first books on manual small incision cataract surgery and has been teaching this extensively over the past 2.5 decades. She has, of course, numerous academic awards to her credit and numerous book chapters and gold medals. I won't go into them because, ma'am, we would like to hear more from you. So over to you, Ruchi, ma'am.
Thanks, Parikshit. And thanks, Dr. Partha and Dr. Bhalla. And I think it's always nice to speak on SICS, a subject which is quite close to my heart. I started my residency writing this book, so it's really nice to be with it always. Now, I think the topic which has been given is SICS with trabeculectomy, and see, I'm not a propagator that one should learn just one technique. I would say that one should know FACO, SICS, all the techniques equally. But there would be situations where I would definitely go for a SICS trap vis-a-vis a FACO trap, and those would be a lens-induced glaucoma, a very hazy cornea with a very hard cataract where doing phaco emulsification is going to be tough. And already if the pressure has been high for long period, your endothelium may be compromised and your corneal integrity may not be all that good. So these are the other usual indications that we have. Now I'll directly go on to a video presentation. This is a case which came to us. She had an extremely shallow anterior chamber. It's an old patient, 65 years, and the pressures were high to the range of nearly 40 millimeter of mercury, and without drugs. And as you can see, the pupil was fixed, dilated, and it was not constricting. So the diagnosis was either a lens-induced glaucoma or it was basically an ACG with coexisting cataract. We looked at the other eye, and the other eye also had a similar picture. Probably she had again presented in an attack and got herself operated. So I'll just go through the steps of SICS with TRAP, the procedure that we follow. So you can see the cornea is so hazy inferiorly, and the pupil, look at the irregular pupil. Nowadays I prefer to use a limbus based flap, and the important part is that we need to dissect very carefully, both anteriorly as well as posteriorly, a very minimal cauterization. And this is the flying eagle technique of the incision, which myself and Dr. Malik has published in DJO. And you can see this is how the center rectangular shape flap with a frown on either side. This is about 2 millimeter from the limbus. A very careful dissection using a crescent blade anteriorly, about 2 millimeter again into the cornea. Most of these eyes are going to be extremely congested. You can see there, this is the, I also prefer to use a NTA chamber maintainer. Staining is particularly important, and as now you can see, the capsule is wrinkled over here, the cornea is hazy, the chamber is practically flat. So one has to be very careful. Rhexis was not possible with the cystotome. So I decided that after staining, I'll use a capsular rhexis forceps to create whatever capsular rhexis I can. Now again, it is extremely important that you should place the IOL in the bag, because once you're doing a trabeculectomy, if your IOL is not in the bag and you're not able to dilate post-operatively, you tend to get more synegy formation. So this is the hydra expression of the nucleus. And once I put on the red glow, now see how bad the cornea was. You can hardly see anything. So this is the PMMA lens which is being placed into the bag. And after putting pilocarpine, we could hardly constrict the pupil. I don't use a punch. I use a MVR blade. So you can make two small entries, and you can use a vanas to cut a block. This gives a very neat kind of a sclerostomy, and this is a peripheral iridectomy being performed. And this is to check whether an adequate aridectomy has been made. Two sutures are placed on either side of the flap, and the meticulous closure of the conjunctiva is important. Also, it is important not to over dissect the conjunctiva, because we may need a second trabeculectomy at a later stage in any glaucoma patient, and even a glaucoma drainage device. So, important message is that we should not dissect too much of conjunctiva whenever we are doing SICS. So you can see a nice bleb being formed superiorly, and the intact bridge of the corneal lip, it helps in decreasing the prevention of against the wound drift, as well as the post-operative hypotony. Now, to conclude, SISAs alone may be done if the target IOP is achieved with medication. Alteration of incision site may be required if it's a pre-existing bleb. Minimal dissection of conjunctiva, which I'm iterating again and again, is very important in any trabeculectomy procedure. Now, a single site combined surgery lowers the IOP about 14 plus minus 3 millimeter of mercury over a year of follow-up in my hands. And if I need a even lower drop of IOP, I would then, sometimes combine it with MMC. Thank you so much. Any questions are
Thank you, ma'am, for perfectly sticking to the time. I would request Dr. Dhaliwal, sir, to give his comments on ma'am's this. Please unmute yourself, sir.
Yes. I'll not have many comments to make about Ruchi's presentation, because I'm from a place, small place, small time practitioner. I have always uh, been wary of combining the two surgeries. I found it paradoxical to operate for cataract as well as glaucoma, because in cataract I always wanted a perfectly sealed wound, and trabeculectomy, to my teachings, to my uh, experience, was basically not a trabeculectomy, it was a filtration surgery. And so I would always be preferring one sealed surgery and a filtration surgery the second time. And in between, I would rather try to control the pressure with glaucoma, or the glaucoma with drugs. But Ruchi, with her teaching experience and the research experience, I think she works wonderfully well.
Uh,
Thank you.
can I answer, Parikshit? Can I answer?
Yes,
Oh,
of
yes,
course, ma'am.
yes, please.
Okay, sir. What you are saying is kind of perfectly correct. There are again, one can really not generalize any situation. Now, there
Oh,
will be
yes.
a situation where you have a point 0.9 cupping, and you're lowering the pressure is more important than, doing a cataract surgery. And that is only possible if you are able to see the fundus. That means your cataract is not all that advanced. So there, I would agree. I would only go for trabeculectomy, and I will not go for a cataract surgery in the first instance. Now, there is an instance where your cataract is so advanced that your, management of glaucoma is going to be hindered. One, because you cannot see the fundus details properly. So, and the second is that you cannot do any perimetry or any other investigation because of that. In those cases, I think it would be preferable to go for a combined surgery. Now, whether I would go for a single site or two site, again, if I want a more lowering of pressure, I would go for a two site surgery. If I want a lesser lowering of pressure, I would go for a single site surgery. Now, there is a third scenario where which I showed, that you have a lens induced glaucoma, or a very extremely shallow AC, a hard cataract, or a cataract which is too advanced. There, I would go for a combined surgery with a manual small incision cataract surgery. So again, sir, as I said, one can really not generalize anything in any patient. So the management would differ. Yes, please, sir.
And ma'am, also we have a lot of patients who are from rural background, who are poor, or we are not sure about their follow-up. So if we do a cataract and just put them on medication, they may not put the medication, or they may not come for a regular follow-up. So
Absolutely.
managing glaucoma in the same setting has many other effects also.
Absolutely correct.
So,
Absolutely correct.
I think very well done.
Dr. Bhalla.
Can we have some comments from Dr. Deepak? Dr. Deepak, you are muted. Deepak, I agree with Dr. Ruchi. Only thing is, I'm more in favor of doing two-side surgery rather than single-side surgery, for the simple reason being it causes less trauma and less chances of bleb failure subsequent period. Otherwise, I think it's very well done surgery in Dr. Ruchi's hands.
I would again go for a single site when it comes to SICS.
Yeah, two
Because
sides
doing
is
a twin site in SICS is a lot of conjunctival dissection.
Yeah.
As a glaucoma surgeon, we would like to preserve as much as possible the conjunctiva virgin. So when
True,
it comes
Dr.
to SICS trap, I would always prefer a single site.
Yeah, true, sir.
Just to answer Dr. Dhaliwal's, dilemma as to whether it should be a tight wound or a leaking wound, the thing that works best is do a releasable suture. Releasable suture closes the wound, and then you have just the phaco tight wound. And about 2 to 3 weeks later, you can titrate depending upon the response. You can remove the releasable suture. Then you have the best of both the worlds.
Thank you, Dr. Rendra.
Thank you, sir. So